All right. I think I've maybe figured out the intro. Hello, everyone. I am Dr. Brandon VanderWel. Nice to meet you. I am here at Aviva, which is a weight loss center focusing on weight loss surgery, weight loss medications. We do endoscopic surgery, pretty much a very comprehensive weight loss approach, as well as the sequelae of weight loss, of obesity, which is diabetes, hypertension, sleep apnea, liver dysfunction, PCOS. We help them all. So I am a board certified general surgeon with a specialized training in minimally invasive surgery and bariatric surgery and metabolic surgery. So can't wait to speak with you guys. I'm sorry we're having my software, got an update. And so it's been a little bit different from what I usually run with. So here we go. As always, if you have questions, please put them in the comments section. I'll try to see them. I have my phone going on the side, but some things changed on the software side, so it may not pop up here. So yes, let's see, chat. Yeah, let me know in the chat if it's working, and hopefully we will not have any trouble. So, all right, I have a little talk here. I'm just gonna try to, keep everything nice and easy. And my goal here today is just to kind of share a little bit of, our experience about weight loss and about obesity and how we treat it and how we treat all the other comorbidities that go with obesity, like diabetes, hypertension, sleep apnea, non-alcoholic NASH, fatty liver disease. These things are a real scourge of disease on our population in the world, in the United States, and they're very hard. Weight loss is really hard. So, all right, here we go. At the top. So this is our clinic. We have been doing bariatric surgery actually since 2007. One of the first places in the world to do an outpatient bariatric surgery, a laparoscopic sleeve gastrectomy in this area in the Pacific Northwest. One of the first in the world to do an outpatient gastric bypass. And that was over 15 years ago now. So getting close to 20. We're close to 20. So have a lot of experience in this, helped thousands of patients. We've helped patients lose an unbelievable amount of weight. And so with that experience of doing all different types of interventions for obesity, really can't wait to share what we have learned through these things so that you can really understand what it is, what these things are and how to get the most out of them. So, and see if you're out there struggling, what's going to be the best thing for you. First approach I like to take, as always, why is weight so hard to manage? Why is it so hard to lose weight when even though I'm trying very hard, it's constantly a struggle. And I like to say that our bodies are not made to survive in the 21st century when we have comfort and abundance. What we are made to survive is hardship and scarcity. So if you are challenged with what's going on in your body, that's a normal thing. Like, our bodies are made to not live in completely climate controlled environments for most of our day. Work is generally very hard, your body thinks, and you are very arduous. Transportation is challenging. The foods that we eat are different. The ability to store food is not a given. The ability to have access to food is not a given. And so everything about our life in the 21st century is easier and is wonderful in that way. I love my warm showers and my light switches that turn on and, modern travel and how safe and comfortable it is. But none of these things, nothing that we do in the 21st century, and every year we do things that we actually use less calories than we did the year before. Arguably the one thing that we've done differently in the last 10 years to maybe consume just maybe a few more calories is the invention of the standing desk. So this is a very challenging issue. Your body just thinks it's constantly going to die, not survive the winter, and famine is coming, you're going to starve to death. So it doesn't believe that Costco exists. It doesn't believe that refrigerators exist. And it just constantly wants to tell you to go find some food and eat some food, because that's been essentially how we've gotten here. That's all of our ancestors have had to really deal with. Weight loss tools. So let's talk about okay, I'm struggling with my weight. What can I do? Behavior modification, The Biggest Loser. I made this slide before The Biggest Loser documentary came out on Netflix, which has become, significantly more scrutinized now. And it's the common adage of eat less and exercise more. And that's what's so hard about weight loss, is that isn't bad advice. Like, that is the way you get there. It's just, how do I maintain the consistency of a caloric deficit when your body just fights a caloric deficit every time it gets a chance? It's very, very challenging. If you have a long ways to go in your weight, it's very challenging to be successful long term. And that's what they saw in The Biggest Loser in the show, when they had extreme interventions of extreme diet, extreme nutrition things, extreme exercise. Their challenge of maintaining that weight loss off was very, very hard. And most people gained their weight back. Most people actually, in a lot of those seasons, actually went on to get surgery. I've done surgery on a Biggest Loser contestant, and that's what they said. In their internal Facebook groups, most people struggle. They gain almost all their weight back, and most of them actually go on to get surgery. So, and if you just want to talk about numbers, so the chance of, if you need to lose a meaningful amount of weight, and I think a meaningful amount of weight, let's just use a ballpark figure, somewhere between 60 pounds, which might be, if you need to lose 30% of your body weight or more, so somewhere between 60 and 120 pounds or more, the chance of you doing that, if that's more than 30% of your body weight, the chance of you being successful with that and keeping that weight off long term is less than 5%. So it's not zero, it's 1 in 20. But if you told someone, hey, you have this condition, you have this medical device, here's the best first line medical device we're going to give you, and the success rate of that is 5%. That's not very good doctoring. Like, it's not a very good treatment option. It's safe. It doesn't hurt anyone to try these things generally. It's just not going to work very well. So we have to think, okay, are there things that we can do that have acceptable costs and safety profiles that are going to help us be much more successful in this? Enter weight loss medications. So this is I call them legacy oral medications, the tablets, the pills. And so these medications are like the phentermine, the topiramate. These are tools that if you are struggling in the past, like even though it's 30, 40 years ago, we have used these medications in various forms to help people get an edge. And usually what they are appetite suppressants. And they are, which is mostly the phentermine part, and they suppress cravings, like some of the draw towards food, which are a little bit different. Those are little different things. Which is helpful, takes the edge off of things, is what patients describe it as. And the success of that's about 5 to 10% total body weight loss is the average weight loss. So not nothing, but not amazing, really. Most people that come to us are looking for more than 5 to 10% total body weight loss. Enter, now the most popular thing, the injectable GLP-1 medication, so the Ozempics, the Mounjaros. There's two major common ones of these. There's semaglutide, which is Ozempic, which is the diabetes designation, and then Wegovy, which is the obesity designation of the same drug. All these things are the same drug, and that's a GLP-1 agonist. And GLP-1 is a hormone that your body makes naturally. It makes you feel more full, less hungry, slows down your intestinal tract. The other drug that we use is tirzepatide, which is a GLP-1 plus GIP, which is gastrointestinal peptide, also a naturally occurring hormone. And that is, tirzepatide is Mounjaro as the diabetes designation, and then Zepbound as the obesity designation. The hormonal levels of these drugs, when you use the maximum dose, is almost order of magnitude higher than your body naturally experiences. It's a very heavy hand of a hormone. The effect of that is significant suppression of your appetite, slowing down of your gastrointestinal tract, slowing down a feeling of fullness. And interesting psychologically, there just seems to be less dopamine activation that seems to happen with a lot of almost vice-like activities in general, overeating being one of them, alcohol being another, opiates, gambling addictions, shopping addictions. I do a lot of these medications myself for patients, and I hear this regularly. It's like, man, these things that really were sort of a compulsive, almost addictive drive for me before, they really don't have that much power over me anymore. And I'm pretty ambivalent, which is fascinating. It's a fascinating interest, like look at how our body and how all these things are interconnected. The success rate with these in real life is usually around somewhere between 10 to 15 to 20, maybe 20% total body weight loss. Tirzepatide does do better than semaglutide from a weight loss standpoint. Making sure we don't have any chats. Yep. So these are good. These are really interesting drugs. A lot of people would describe it. The first thing people generally describe is it just really decreases this food noise. That constant talking of food. I kind of describe it also as a gravity. Like, you know, that if there's food around, you have this gravity sort of pulling you towards that food constantly. And what people say is this really seems to free them up from that so they can just get on with their life, which is wonderful. Like that is so freeing and something that many people that struggle with their weight for a long time have really just never experienced. And they're just like, what do you mean? You mean I can just be in a room with food and not constantly be trying to think about it and fight against eating it and putting it in my mouth? And it's very helpful. It's very helpful. So we do a lot of this in our office. I think it's a really helpful tool. But truthfully, most patients are looking to get more out of it than what they experience. And there's millions, millions of people have tried this drug, and millions of people have been disappointed with it, which is not something it seems like it's, I think is in the popular lexicon out there of, they're just like, wow, obesity is essentially cured with Ozempic. You just need to, you just need to take it and you're good to go. And unfortunately, that's just not been very true. So we need to think about what are our other options. If you're out there and you've tried one of these medications and it hasn't worked for you like you wanted to, you're honestly not alone. Not even just are you alone, you're actually in the majority of people that use this drug, which is they have some benefit, but they're like, I still have I still have quite a ways to go. Then this is not where I wanted to stop. I want more out of this. And unfortunately, you're just trying to essentially hack your body's system by overloading it with the GLP-1 hormone. And most people that struggle with their weight don't have a grossly deficient GLP-1 hormone in their body. There may be some evidence that there's some GLP-1 dysregulation, but not to the extent that you need to 6, 5, 8, 10 times that hormone. And that is what your problem was. It is that this is probably just hacking a system and pushing a lot of buttons in a very heavy-handed way. So what else? What's the next step? So this is where we kind of cross what I describe as the anesthesia line. And this is where we get into procedures. So these require anesthesia. You want to take some time off to recovery. And the first one that we'll talk about is the least invasive one. That's the endoscopic sleeve gastroplasty, the ESG, or the endo sleeve. It's a very cool tool. We've been doing this. We were one of the first people in the Pacific Northwest to do this surgery. I think we've done more of these than anyone else in the West United States. It's a very cool procedure. What it does is it uses a suturing device on an endoscope, and it goes down through your mouth, and through the mouth actually goes down into the stomach, and then sutures the stomach from the inside with a series of sutures. We use a lot of sutures because I want this thing to be really strong and really tight to reduce the size of the stomach and make it so that you can't eat as much food, number one, you're full faster, and you actually have less hunger. The way that it does that is that the internal lining of your stomach, the cells on the inside of your stomach, those are very hormonally active cells. And they are the part of your body that's generally that is sort of the find food, eat food talking mechanism here. That's what I describe that as. How your body kind of manages its blood sugar and to some extent blood pressure, I think is actually, blood sugar particularly is definitely actually a little bit more small bowel than in the stomach part, but it certainly is. The stomach also plays a piece into this. And when you crumple that stomach down into a smaller shape, you have less surface area of those cells that are interacting with food and less communication. So people describe themselves as feeling more full. They don't need to eat as much food, and then they're also less hungry. And the weight loss from this that we see in our practice is usually around the low 20%, 20 to 25% total body weight loss, which is really cool. It's a very helpful tool. And what's nice is that you're not removing any part of the stomach. You don't actually have any incisions. The recovery is usually about 2 to 4 days. And it's a very nice intervention, and it helps a lot of people really make some good progress about where they want to go. It also has just less serious adverse events. Like, because you are inside the stomach, you're never actually poking out of there. Your chance of hurting something in the abdominal cavity or elsewhere is very, very low. It's never zero. Like, there's never zero risk of anything in life. But the risk with this procedure is very, very low. And the long-term issues, which is always people's concern, are like, okay, if you're doing surgery and you're messing with stuff in there that was normal before, what's the downside of that? What's the cost of that long-term wise? And that would be, I say, like, generally we have very low drama with the endoscopic sleeve. It's very rare that people have long-term complaints with this procedure. Obviously, probably the biggest downside is that, having sutures keep your stomach closed down for a long time is harder. Like, it's just not, the stomach's it's a strong muscular organ, and it's going to be working against some of those sutures. But, we've had patients, we've been doing this for 5+ years now, and have patients do, be really successful with this tool. So it's a very cool tool. And the perfect person for this tool, I think, is someone who says, I need a little bit more weight loss. I really want to have a smaller stomach, but I don't think surgery is for me. Like, the idea of, getting incisions, removing part of an organ or moving things around just really doesn't sit well with me, but I know I need something extra. But I'd really consider this, like, seriously consider the endo sleeve. Like, it is a really cool tool. If you're not going to do surgery, it gets better results than our medications do. And plus a little bit of medication is magic. It's awesome. Really good. So, the really cool tool. Is this as good as the next tool, which I'm going to describe as here's the next step is the suturing, and you crumple it down. So this goes into now the bariatric surgery piece. So this is the next line, that sort of dotted line, which is incisions, and having actually manipulating and permanently affecting the GI tract. This is where the laparoscopic sleeve gastrectomy is the most common surgery that we do, and for good reason. It works very well, has great weight loss, is very well tolerated, it's very safe in experienced hands like ours. What you do with that surgery is you take that big bag, which is the stomach, and you make it into a small tube again, but you actually seal it with a device like this. So this is the stapler. You can see in there, see all those tiny little dots in there. When your stomach, we put this down, we put a little sizer inside of your stomach so that we know exactly how big to make it. And then this thing clamps down, and then it seals those with tiny little staples in multiple rows. Like, I think there's like 100 staples in here or something, every single load. And then it seals it, and it cuts, and seals, and it cuts. So actually nothing's spilled, nothing leaks out, and it works really nice. And you just you just march up the stomach along there, like arts and crafts almost, which is most of surgery in general. Surgery is a mix between, like woodworking and plumbing, honestly. So it's about precision, it's about figuring out fluid dynamics and how it all works together. So it works super nice. Having a smaller stomach is just really, really helpful. We usually get a little bit better weight loss with the laparoscopic sleeve than the endoscopic sleeve. Usually we're talking about, 20-25% versus 30-33% total body weight loss on average. There's certainly overlap there. Definitely overlap, but the difference is that the laparoscopic sleeve is probably a little bit smaller. It's a little bit more narrow. And because you're completely removing that extra hormonally active cells of the mass of that extra part of the stomach, there's just less hormonal activity coming from your stomach compared to an endoscopic sleeve. Both of them are great steps forward. The laparoscopic sleeve, though, generally people, what they describe as they're actually less hungry, like as you're removing more of those cells, less hunger, and a little bit better weight loss, and certainly satiety, early fullness. And really nice surgery. It's probably its one downside is that about 15-25% of our patients in our practice experience a little bit of worsening heartburn than what they did before. Rarely does it be severe, that it's not manageable with, Tums or medications. And we have to, look into other things. So the chance of that is it's 1%. So, But the nice thing with that surgery, it's very safe in our hands. Our complication rate from that is less than 0.5%. Very well tolerated. People do really well with it. So, yeah, great. It's a great surgery. And a lot of people's questions are, so the endoscopic sleeve and the laparoscopic sleeve are making the stomach smaller and into a tube shape in the same way. Are they the same size? Are they essentially the same? One's just different. They're just different approaches. Yes and no. So they are pretty similar to the same size right after surgery. I do try to have a very aggressive endoscopic sleeve that makes it, tight and very secure. But I tell people on my best day, suturing is only as good as I am with the stapler, with the laparoscopic sleeve every single time. Don't get me wrong, I really enjoy doing the ESG. I love seeing patients doing awesome with it. And I have hundreds of them doing really well with it. But it is, it's a tool. All of these things are tools. They're not cures. They're not magic wands. And if you use the tool well, it can do really well. But tools do have different strengths and weaknesses. Medications are tools. They have different strengths and weaknesses. Endoscopic sleeve is a tool, laparoscopic sleeve, and then the gastric bypass, which is the next one. They all have strengths and weaknesses. This is just like any other tool that we use in our lives. So the gastric bypass, this is the one where you take the stomach and make a small pouch out of it, and then you bring up a piece of small intestine and you actually reconnect it. And you change the flow of where food goes in the intestines. Again, it's that same hormonal activity piece of not only is your stomach smaller so you can't eat as much food, but when food interacts with different parts of the gut, of the small bowel, and it's not digested, your small bowel sends off all these crazy hormone signals that says, whoa, time out. What is happening here? I should not be seeing undigested food in the mid to distal small bowel. And so it sends out all these different hormones that make it very favorable for you to help you manage your blood sugar better, to actually lose a little bit more weight, to be less hungry. Fascinating stuff. And we're learning about this more every year right now. Some really interesting surgeries, really interesting science being done that shows how much of the gut really is what we describe as the conductor of this complex symphony that is our body's management of, its weight, its blood sugar, its blood pressure even to some extent, and a bunch of other different, hormones that are in your body. And it's just fascinating to see how these, really significantly, make very positive changes when you address the prime issue, which is the gut. So, and that being the stomach and the small intestine. And they both have and they all have different roles, it's a very fascinating. I love my job as a bariatric surgeon because I get to see the whole spectrum. I'm helping people lose 30 pounds. And sometimes with a little bit of weight loss medications. I tell some people need to lose 200 pounds and they still want to do just medications. And hey, this is your life. I'm here to help you with whatever tool you want to think is going to be the best for you. But what I see with that is a very different experience than the people that need to lose, let's say you need to lose 80, 70 pounds. And the difference in experience between medication and the endoscopic sleeve and laparoscopic sleeve and gastric bypass is fascinating. It's really interesting to see how different interventions, different tools, different tool combinations together really do affect what your experience is in your body and how those things all operate together. So, yeah, any questions, put them in the comments. I think I can see the comments, maybe. So let's see here. I'm just gonna test the comments here real fast. Test, maybe, question mark. Wonder if I should have done that before. Yeah, that'd been a good idea. So, groovy music. Yeah, it looks like Chris said earlier, and I didn't see that. So hopefully there weren't more comments out there that I missed. All right. Okay. So we're talking about, here's some real life data from our practice about like, what do these tools generally do? Like comparing, this is 36-month data. So 3-year data of GLP-1s, which is the bars in blue. I'm sorry, these are kind of small. There's green, which is the endoscopic sleeve, and there's purple, which is the laparoscopic sleeve. And it's really interesting to see how you can see there's a really big difference in the common experience between a GLP-1 alone, which is, really between 5 and 15%, which is, Unfortunately, people in the real world, our practice included, pretty much every published data set of like not industry sponsored trials show about this results for GLP-1 medication. Endoscopic sleeve is in that the average here is in that low 20% range, which is really cool. Laparoscopic sleeves in the low 30s. And what you should notice here, and I wanted you to take note, is that when you see how this all plays out, 75% of people that get an endoscopic sleeve, the green thing, 75% of people, this box and above, are doing better than 75% of people that do the GLP-1s. And 75% of the people that do a laparoscopic sleeve are doing better than 75% of people that are doing an endoscopic sleeve. This is just our data. And this trend stays pretty consistent out to 3 years. We don't have 3-year data on GLP-1s alone because number one, we don't have enough patients. It's not generally an old enough drug, but truthfully, seeing this in the long-term thing, most people just don't lose enough weight. Like they don't. And if they do, if they are in this top echelon of treatment, usually by that time they've tried to stop the medication, and some of them, a small percentage, less than half of the people that do really well, less than half of them can keep the weight off. The majority of them actually gain a significant of their weight back. So the amount of people still on medications alone at 3 years is low. So that's unfortunate as part of the data. And I don't know what it's going to be like for people, for what your experience is going to be, but I think what these tools reflect is they have different strengths, different weaknesses, different targets. And it's really helpful to have meaningful interventions on your GI tract. It's very helpful for maintaining and being successful from a weight loss standpoint. So anyway, hope you all enjoyed the presentation. And yeah, thank you for watching. If there's any other questions or comments, you're welcome to put them in the chat. You can put them in the chat later too. We do kind of go back from time to time. I go back through what our comments are and try to, address them at some point and get a feel for, what people would like more content about. You're welcome to check out our Aviva MD YouTube site channel. We try to put, some helpful content on there that's going to help you in your weight management journey, because it's really hard to manage your weight in the 21st century. It's no joke. And we understand that. We're here for you. And we have lots of great tools to offer you at every level, whatever you're going to be comfortable with. So please reach out at avivamd.com, should be in the description, and can't wait to connect. So I hope you have a great day.